Hey guys, welcome back to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US.
We are your hosts. I'm Dr. Amrit Bilku.
I'm Dr. Deepan Kaur.
Hi, I'm Dr. Ravinder Randhawa.
And I'm Dr. Alex Kuhn.
So today we are talking with Dr. Danielle Piser to learn more about how we can manage cataract patients before and after surgery. Dr. Piser currently works as a full-time clinical faculty instructor at the Illinois Eye Institute and serves as the chief of the Alfred and Sarah Rosenbloom Center for Vision and Aging. She concentrates in geriatric eye care and vision rehabilitation, and she also has years of experience managing patients alongside ophthalmology by performing cataract pre-operative and post-operative examinations. We learned a lot from Dr. Piser today, and we hope you all do as well. Dr. Piser, thank you so much for coming onto our podcast today. And for any of our listeners who did not go to ICO or who are not aware of who you are, would you mind please telling us a little bit about yourself?
Sure. I'm Dr. Piser. I work at the Illinois Eye Institute. I've been there for over 10 years now. And I say the Illinois Eye Institute because that's primarily where I practiced. I was part-time faculty at ICO starting right after my residency in low vision and ocular disease. And I went and actually worked at DuPage Medical Group for about 5 years, which was a OD-MD practice. And so I got some real world experience doing mostly glasses, contacts, and then finally got to do some post-op work and diabetic eye exams. So then I came back to ICO, worked for the Illinois Eye Institute as a staff optometrist, and then came faculty just this past August, so almost just a year ago. So I was never full-time faculty. Thank you. Yeah, and then actually became chief of the department and Rosenbloom in March of 2018. So that was exciting and scary, and it's been a new experience for me, but really enjoying it and definitely doing something a little bit different in optometry. One, I never thought I'd be in academics. And then second, ever thought I'd be in administration. But I think that's what's great about optometry, and that it has a lot of different avenues that, are available to us, and that we can go in different directions whenever we want to. So that's been really awesome. And ICO has been really, really great. I'm originally from Ohio State. That's where I did my optometry degree. So it's great to be at a different school and have a different family. And it's, it's been a really great family to have.
I know, that's why we were really excited to have you, especially because you had a lot of experience working side by side with cataract surgeons and other MDs. So that's why we felt like you were the perfect optometrist to bring onto our podcast today.
Well, thank you.
Yeah. So Dr. Piser, as our first question here, as optometrists, we typically make the initial recommendation for the type of IOL that would best for the patient when discussing surgery. So in your opinion, what are some important factors to consider when recommending each type of IOL? And I'm talking about like monofocal, toric, multifocal IOLs.
So in regards to how I choose an IOL, it's right off the bat, how do I want my patient to see? Okay, what's their potential for vision? And then asking them, how do you want to use your vision after cataract surgery? I think that's the most important question. And oftentimes they're like, well, what do you mean? What do you mean, how do I want to use my vision? I just want to be able to see. So I ask them, what's the most important vision that you want to see corrected? Oftentimes, I don't care, I just want to see better. But sometimes people say, oh, I just wish I had better reading vision, or I wish I had great distance, or I wish I didn't have to use glasses at all. So when patients tell me, again, they don't want to have glasses at all, I'm more inclined to maybe think about doing a multifocal or educating my patient more on a multifocal option. I base it off of the refraction, or the type of refracted error that they're used to having. So with a hyperope, I'm more inclined to go towards plano, right? Or maybe myopic if they want to be able to read up close. With a myopic patient, though, I'm getting nervous about taking away that myopia, because that is a big complaint. Even if they're like a -2 or -3, you think, oh, I'm just going to give them perfect distance vision. They're going to be so happy. Actually, they hate it, because now they're like, wait, what happened? I have to wear glasses for reading now? I never had to do that. So it's for them to understand and educating the patient on what they can expect after surgery. And so I think based off of that, if it's a myope, I might aim to say, hey, do you want just like really great computer vision, or to have something at hand's length? Because oftentimes if you aim them at like a -1, they can still walk around without glasses, right, to do everyday type of activities, but they still maybe have that intermediate distance or like a dashboard distance or computer distance they might be still being okay with. And the other thing is I look at the A-scan. So I don't know, I'm lucky enough that I actually get to run A-scans. I know what the A-scan looks like. So based off of that, I can provide better recommendations. So if I have an A-scan and I know that residual cylinder is going to be greater than -3/4 of a diopter, then I'm most likely saying, hey, you are a candidate for multifocal option. So I will explain that to them. And when I do explain a multifocal option, I tell my patients, I can get you out of glasses about 90% of the time. You want to give them that hope that they are going to see improved vision, but that they still might need help either at distance or near, or have like some glare issues, things like that, where they might need sunglasses. But I do the same thing when I offer a multifocal contact lens, right? You never say it's perfect. You say, hey, this lens is more expensive, but I'm going to be able to give you good vision 90% of the time. That other time, we might need to supplement that with glasses or different lighting. That's pretty much how I choose it. I actually talk about monovision, monofocals, and that's just because it's a cheap way to do it, especially if they were in a contact lens and they were doing monovision. I might just keep them the same. But if I do a monovision type of fit before cataract surgery to give them the option, especially if their cataracts aren't too dense, with my patients, that's not going to happen. All of my patients are like light perception when they come in for cataract surgery. But like if I were to work in a private practice, like when I used to work with my surgeon at DuPage Medical Group, we would try monovision with our patients prior to surgery to say, hey, this is what it's going to be like. I throw a contact lens on, see how you do with this for a week or two. If that's something that you want to do, then we'll go forward with that. So I think it's just education and setting up expectations correctly is how you have to provide education for your patient and choosing the proper IOL.
Yeah, it's so true. Never promise your patient that 100% they will get the vision that they want out of cataract surgery. Always leave a little bit of room for the expectation that it might not go the way that they're hoping for. Because when it does happen, we don't want them to be as upset as if you promised 100%.
Right. Well, especially when they're paying $5,000 for laser assisted cataract surgery plus a multifocal, and you're saying, oh, we have this wonderful technology. And then you're going to be 20, 30, 25, maybe 2020. So that's not always a good expectation. I mean, and you have to think about the retinal disease or other ocular conditions that they have too, right? So are you going to push a patient that has a history of poor diabetic control into a multifocal implant? No, because they're going to be pissed if their sugars go out of control or they start to have some type of complication. So you want to also keep it as easy as possible for you to manage refractive error after surgery. So if you know a patient is super type A about their vision, probably not going to recommend a multifocal IOL at that time, just because you're going to have to deal with it and you're not going to want to deal with it.
Yeah.
So,
and then even aside from IOLs, in recent years, light adjustable lenses entered the cataract surgery world in the US in order to provide patients with a customized refraction. So have you personally encountered any patients using LAL yet?
So you guys are way up on your technology, because I read about this maybe years ago, and I didn't even realize it was like out there. So, you guys know where I practice. I practice very low income, severe cataracts. So I had to actually go back and look this up again because I couldn't remember how the lens actually worked. So again, I don't have any patients that work with that. I think it's a really cool idea. I don't know if they've perfected it from like 2017, I think, when they first started coming out to now. There's a lot of questions that I have in regards to offering this to a patient. I don't even know any of our surgeons that are doing high-end cataract surgery that are using these lenses in Chicago yet. I guess maybe I'm not as bougie in the cataract surgery world. But I know that they actually don't really give the prescription, just like we would say, okay, you're going to get a pair of glasses at, 17 days to 5 weeks after surgery, right? So you'll get your glasses then. Instead, they're doing these light pulses to change the lens and accommodate, which I think is really neat. At the same time, I am a little concerned about UV light, and offering that to patients, especially in the aging population, that might have more of a risk for macular degeneration. Also, they say that there's no changes after the certain treatments, but I don't know how guaranteed it is. I didn't look up to the base of the research. And to pay extra money to get this lens, but still having reading glasses. I don't know how much they've done with multifocals and LAL lenses, so that would be something else I'd be concerned about. But I think it's a cool technology that definitely offers a competitive lens, which we don't have a lot of competition in IOL. So anything new, I think, is always great to push the envelope, right? We always want new technology out there, seeing what we can do, what is available to make our patients happy. I mean, I think that's the goal, that whenever we get into medicine, what can we do to, make the quality of our life for our patients much better.
Yeah.
With dry eye syndrome can reduce the accuracy of measurements for cataract surgery and may eventually lead to inaccurate IOL calculations. In your experience, at what stage does dry eye disease consider postponing surgery until the ocular surface is optimized?
So, yeah, I mean, especially with our elderly patients, dry eye is a huge, huge concern, specifically with lid disease, right? You guys have all been in Rosenbloom. You know how bad lids look, sometimes so bad that you have to clean them off in the exam room, which means we're not going to do cataract surgery for that for a while. So, we worry about infection. Endophthalmitis is our number one concern when we do cataract surgery. And we also want our patients to be comfortable after surgery. We are cutting the cornea. Increased dryness after cataract surgery is very common. So in regards to IOL calculations, we actually try not to touch the cornea. So what our students are doing, or our techs are doing, is we're working the patient up by just kind of getting a case history, doing maybe slit lamp really quick to look and see the lens, do refraction, and then we are actually just sending them right to the IOL master or the lens star, which we use. So we get those calculations without touching the cornea. Oftentimes our techs and our students are trained very well to know, hey, let's put an artificial tear in the eye before we start IOL calculations. So that helps, I think, in making it accurate. Whenever I start to see severe conjunctival dryness or PEE, especially centrally, or actually around the lid margin, I'll try to work around that in regards to starting dry eye treatment right then and there. Most of our patients are not getting surgery for another 2 to 3 weeks after that. So I will start them, maybe on Muro sometimes, because I know they might have some swelling after surgery, especially if they have, any signs of Fuchs, or they're older patients or have dense cataracts. So I may start them on Muro before that. Artificial tears, ointments. Sometimes I'll start them on an erythromycin or polytrim prior to surgery, just to kind of clean up their lids, talking about warm compresses, and then using any type of lid scrub that's on the market that they want to use. I would discourage surgery or put it off if it was so bad that there's just clumping around the lashes, tons of scurf, MGD is really severe, and there's controversy. Do we put patients on Restasis or Xiidra before these surgeries, because again, it's immunosuppressive drug, and do we want to is that going to expose our patients to more infection or not proper healing? I have not found that to be the case. I typically do keep my patients on Restasis or Xiidra or Cequa, which we've just started using as well, to help with the dry eye, just because if the inflammation is there, the inflammation is going to get worse and then cause inflammation throughout the eye. So I've been keeping that on them. I haven't had any patients have issues with healing or anything like that after using them.
Yeah. So kind of going back to the whole dry eye concept. So are there any particular signs or symptoms of dry eye disease that may affect post-operative visual outcomes and thus reduce patient satisfaction after successful cataract surgery?
I think MGD is actually probably the biggest ocular condition that would, increase complications after surgery, just because where the wound is, oftentimes is where the lid is covering that, that area. And increased bacteria in that area can definitely lead to endophthalmitis, even if we're possibly even doing an injection of, an antibiotic. I mean, it still could cause infection of the front surface of the eye, leading to an ulcer, something like that. So, I think lid disease is something that's overlooked often. So, yeah, I would say MGD is probably the biggest one. And then Fuchs. We really got to make sure we're preparing that cornea the best we can, and actually communicating with the surgeon. We want to do an endothelial cell count to make sure that we don't need to move on to a combined surgery. And then actually what I'll do based off of how severe the Fuchs is I will go ahead and prescribe sodium chloride about 4 times a day, either starting 1 day prior to surgery or 1 week or even that day, a couple weeks prior to surgery. So that way our corneal swelling isn't bad, and then we're not leading to bullous keratopathy, things like that, which could lead to perforation or eventually needing corneal surgery in the future. So luckily I've only had 1 or 2 of those that needed to go on to corneal surgery.
Yeah.
The other condition is maybe LASIK. I know that's not considered an ocular surface disease, but we talk about LASIK a lot with cataract surgery and the outcome after cataract surgery. One, because people are now having LASIK 10, 20 years ago. And they're like, okay, can we get your original case? And they're like, that doctor doesn't even practice anymore.
Yeah.
You're like, okay. So it's taking this wild guess. I've had about 3 or 4 patients we've had to go in and do IOL exchanges just because they were so myopic. They had so much LASIK done in regards to how much laser and things like that. So that's another condition that we would be cautious about, in preparing the patient for, ocular surface conditions after surgery, or that could impact their surgery or their outcome.
So once our patient actually experiences cataract surgery, what are some common 1-day post-op clinical findings that you typically monitor until the next follow-up visit? So like in other words, what's the highest IOP limit or level of AC inflammation before you intervene?
For me, I used to say, oh, it's above 30, I'm going to treat in office, and I'll probably treat afterwards. I think the more experience you get with cataract post-ops, I'm lucky enough that I've been practicing with Dr. Dawson now for over 7 years, and I've gotten to do 1-day post-ops. I don't think us as optometrists are as privileged to do that. I've changed my strategy a little bit and probably a little bit more laxed because I know things will kind of turn around just with time. I would say, though, it was always 30, treat in office, try to get them down in office after 20 minutes, again, if they're not going down, and then we might have to add Diamox or burp the wound. Otherwise, though, the other direction I've been taking is that if a patient has a higher risk for glaucoma, their cups are a little bit larger, they have thin corneas, and then they come in, say their pressure is always around 10 or 12, and now they're coming in at like 26, things like that. So my marker is about 10 above normal. So I'll look at their range or their IOP. I'll take their highest number that they kind of get repeated, and then I'll say 10 from there is kind of my cutoff. The other thing is people are steroid responders. So that might be an issue that they come off of the medication, and I might want to monitor them every week instead of every, going through a week to 3 weeks. Once they start coming off their pred, can we start coming off of that IOP lowering drug as well? So the other issue that happens with high IOP is actually corneal edema. So what patients tend to do is they're told to wear this patch home. The problem is when they patch the eye at corneas after cataract surgery is that they put a pressure patch on. So they actually put tons of packing in the box shield and then stick it on super tight. And so they go home, they forget to put their drops in. So now they have a lot of inflammation. They're coming to us. We have to pull the tape off. Hate that.
Every time.
The eyebrow off, whatever. So that's never good. So it's annoying. And then what happens is, so if you think about it, you go to sleep, the eyelid the eyelid's covering the eye, cornea naturally swells. Okay, now you had surgery, your eye's permanently shut for 24 hours after you had surgery, you're old, and you had a lot of trauma. That's just like a perfect environment for you to come out and have like grade 3 to 4 endothelial folds and microcystic edema.
Yeah.
So the patient can't see. So oftentimes you might get a higher pressure because the cornea is so swollen, that throws you off. The other thing is if the pressure's high, the cornea steams up, right? So oftentimes what you'll be able to even do, you'll lower the pressure in office. It will come down really fast at like 10, and now the cornea is clear, okay? So you will see that. If that happens pretty quickly, typically I know that we may want to send them home with something, but probably just lowering in office was good enough, and to have that eye breathe and actually get the inflammation down because of them not using their steroid. Okay. So when they don't use their steroid, the pressure tends to come up because of inflammation. So those cells get trapped in the trabecular meshwork. The other thing is pigment, right? We have, with my patient population, people of color, we have a lot of iris pigment, and that, sometimes the implant can bump up against the iris. We're getting that sloughing of the iris, so the pressure's high. If I feel like it's due to that, or they have a lot of inflammation, I may put them on an IOP lowering drop. So it really is patient dependent.
In your clinical experience, then not just only for 1 day post-ops, but even 1 month or 1 week or 1 month, what are some common post-op clinical complications? And then for each one, I guess aside from higher IOP and corneal edema, what would be your typical methods for successful management of these other types of complications?
So I've been lucky enough that I don't see a ton. We can fix them right away. The number one thing is we see rebound inflammation a lot in our patient population, even if they're doing really well with their drops. If we start to taper them too early, like say, we see them at their 1 week, their inflammation's down to like less than grade 1 cell, we start the taper, and then they come back within a couple days to the ER, the urgent care service, or back in our chairs, and we see rebound inflammation. One, they either stop the drop right away, or they didn't understand the taper, or patients that we work with just tend to have, more problems with rebound inflammation. The other complication that we sometimes get with rebound inflammation is even after a month, like we try to taper them off, it doesn't work, it's coming down, and then we take them off again, and we're getting this constant rebound inflammation. So working with Dr. Opitz and some uveitis specialists, we send them out for testing to make sure that we don't have any major issues systemically. But unilateral uveitis or rebound inflammation is going to make us think more about herpes, right? And because of our older population, I've started asking patients when they have rebound inflammation, have you ever had the chicken pox? Have you ever had the shingle shot? Have you had any of these things? Because if they have, some type of virus that's hidden, and we know that oftentimes the herpes virus is dormant until some type of trigger happens, whether it's inflammation or trauma, some type of stress that keeps it going, we've been actually starting to put these patients on an antiviral, typically not topical, oral, to kind of kick it in the butt. Sometimes we'll do topical as well, but typically we try just 2 weeks to 4 weeks of treatment orally to help with rebound inflammation. Cystoid macular edema is probably the next biggest one that I see after 1 week to a month. If my patient isn't seeing 20/20 at week 1, I get a little nervous. Oftentimes for our patient population, due to economic reasons, we're actually only giving them pred and putting them, using a moxie injection for their antibiotic, or giving them, Ocuflox or something like that. So we don't typically use ketorolac or an NSAID unless our patients have diabetes, a history of inflammation, something like that could increase inflammation inside the eye, and especially of the macula. So oftentimes we'll see our patients start developing cystoid macular edema, 2-3 weeks after surgery, and they're not getting any better. So again, with cystoid macular edema, we'll put them on an NSAID. I typically treat my patients for about 3 months. And then that's kind of my cutoff. If we're not getting any improvement after 3 months with an NSAID, then I'm sending them out to retina. I'm lucky enough now that I don't see endophthalmitis or TAS, which is great. And that's just because of the intervention of using the Moxie injection or the antibiotic injection with cataract surgery, which I know you guys have questions about. But, that has been a huge plus for me. In terms of a Seidel sign, I've had a couple, and actually our surgeon is pretty good. He's like, the cornea still looks good. You can kind of press on it. It doesn't do anything. It's not leaking too bad. We'll either throw a bandage contact lens on, maybe use atropine or pred, increase the pred to see if that helps. But typically it's just because there's a small leak. But I always recommend, if you're working with a cataract surgeon, to call them whenever there is a Seidel, and they'll kind of tell you, hey, just see him tomorrow. If, give them, the information if the eye's gushing, any things like that. We could also go back to a pressure patch.
And so actually, would you mind sharing with our listeners and with us any interesting case involving a post-op complication that you maybe recently have experienced or in the past, and how you managed that situation?
Sure. I would say my most interesting post-op complication was a iStent, a cataract surgery complication combo. So it was right when we first started doing iStents, and I had a patient. He was a ex-Chicago cop, and he had his first eye done and had iStents put in, no complications, everything went great. We had the second eye done, and he came in with a hyphema, just a very small one. And so I wasn't too worried. I know that's pretty common when we get like just a microhyphema with an iStent after cataract surgery. And then he called 2 days later, and he had a full 8-ball hyphema, which I did not expect, because I was like, oh, it's fine. It's just not a big deal. So we got, we did the atropine, we got everything down, and then we could finally see back there after about a week or two. And then he had a vitreous hemorrhage behind that. So that was really crazy. So at that point it had been like 2 weeks out, and so we worked with our retinal specialist, and he really just said, I can't really do anything until the hyphema's all the way gone, and I have to kind of wait for the heme to resolve a little bit so I can see back there. And we ended up finding out that we thought, oh, it was because the iStent was placed incorrectly, or done too roughly. It's actually because he was on Xarelto, which is a blood thinner for blood clots. And so he had never come off of it. He forgot to stop taking it. And so he actually was on that high dose for that amount of time. We didn't find out till after I asked him when he had the vitreous hemorrhage, are you on any blood thinners? And he said, oh yeah, I've had a history of blood clots. I'm like, did you stop taking the Xarelto before the other surgery? He's like, yeah, I didn't take it for like 24 hours prior and 24 hours after the surgery. And I'm like, okay, that makes sense. But I was really curious with that, because, typically with an iStent, we were having such great success, and, to have a microhyphema one day and then an 8-ball hyphema the next was like, oh my God, what the heck happened? And then to have a vitreous hemorrhage on top of that. Patient ended up getting referred to Dr. Itiara. I never saw him again, not surprised. But I got a letter, and he's doing fine. His vision went back down to 20/20. So he was,
wow.
Yeah. I've had a lot of young cataract surgeries lately. So the most recent one we had this week, which was kind of not cool. I don't want to say that because it's not cool. But we had an HIV positive patient that came in and had a very dense cataract in one eye. and a moderate cataract in the other. So he was 28 years old, and we did cataract surgery. And the first day post-op, he didn't see very well. He had always had this like weird visual field defect, like inferior temporal, but we couldn't see back there, so we didn't know what it was. We did do a B scan. It did show some, vitreous floaters or some opacities. So we thought maybe it's an old bit but he was light perception. So he came in, we got him down to like 2100 the first day with some corneal edema. We thought, okay, that's not bad. Dr. Salazar had seen the patient. He comes in for his 1 week and he's like, I can't see anything inferior anymore. So I'm like, oh, geez, so we look at this visual field. I'm like, maybe he just didn't notice it because the cataract, that visual field loss that was there. And we ended up dilating, and we had a superior retinal detachment that was, we think, from CMV. So he only one eye. So that's like, wait, does CMV happen? I had to go back and I'm like, I thought CMV happened in both eyes, and it actually doesn't. It actually is more unilateral with the retinal detachment, because we think, it's a systemic condition. So it actually looked old. He had like a barrier rim of pigment, and I had asked him just to make sure, did you ever have cataract or did you ever have laser surgery in that eye? He's like, nope. So we sent him out. There was no undulation or anything like that, but yeah, we think that it was probably either an old vitreous hemorrhage or neovascularization, causing a fractional retinal detachment. So that was kind of like a cool case, not for the patient, but
that ties back into never promising your patients with what they're going to see, especially when they're light perception. You still can't even promise that you'll see better than that because you don't even know what's back there.
And I always tell my patients that have a dense cataract, I do not know what's going back there. I am going to guarantee that you'll get more light back there. Are you going to get any more vision? I have no idea.
Well, you kind of already answered this question, but what does a typical drop schedule look like for your patients throughout their first month post-surgery? And to what extent do you communicate with the surgeon if you feel like the drop schedule needs to be adjusted?
Yeah, so typically for my patients, because of the patient population I see, low income, very elderly, often have dementia, live in a nursing home, when we weren't using an antibiotic injection, we were seeing more endophthalmitis. So when I first started working with Dr. Dawson, I think I saw 3 endophthalmitises within 6 months.
Oh, wow.
So that was really scary. And I was like, okay, either I'm going to get fired because I keep missing these one day, or Dr. Dawson's going to get in a lot of trouble, or the surgical center is going to get in a lot of trouble because they're not sanitizing properly. So our typical drop schedule now is moxifloxacin injection. And then we do pred 4 times a day, starting immediately after surgery, and then an NSAID if required. Again, I'll do the NSAID starting 1 day prior to surgery. If they have a history of macular conditions, severe ERMs, macular degeneration, anything like that, I might start it about a week prior to surgery, 4 times a day if it's ketorolac, and continuing 1 month after surgery. Typically right now, surgeons, if you work in a private practice, they might be doing the moxi injection. It is off-label FDA, although approved. It's an off-label use for that injection. So they do have to sign on their form that they're doing this. But we found really great success within. The research shows, the risk for endophthalmitis goes down significantly to like 0.3% of risk for endophthalmitis if we do an injection with an antibiotic. So it's great to do that. Then usually they were doing Prolenza or something like that, starting that 1 day prior, once a day, and then starting that. And typically what they'll do with Prolenza is that they'll use that for 2 weeks and then stop the medication. So the research shows that with CME, that it eventually goes away on its own. So you don't really need the NSAID. But again, it helps with pain. It does decrease the risk for, cystoid macular edema after surgery. But typically, if you're going to use it, it's best to use it actually up to 6 weeks, because that's when CME will continue, will resolve completely, excuse me. So that will resolve completely within 6 weeks by itself. So surgeons are cutting it short for 2 weeks. And I think maybe because of the pain, or because if it does develop, it will resolve on its own. So they aren't using it, but I think it's kind of silly not to use it for at least a month after surgery. And then we do a prednisolone acetate, 1%, again, 4 times a day, starting immediately after surgery, continue for 1 week. When I taper, I've kind of gone back and forth depending on if the patient had rebound inflammation before. I'll wait till all inflammation is gone before I start to taper my medications. So we do a 4-3-2-1 taper, and we actually do it with the Cataract and the pred. And that's for us a compliance issue. So our patients can't follow instructions. They decide that they're going to taper their Cataract and stay on the pred, or they stop the pred and taper the Cataract. So we just make it easy for them. So that's mostly what our drop schedule looks like. So for dropless cataract surgery, which we did when we first started, as we started looking at the research for what we call trimoxy. And trimoxy was moxifloxacin with a type of dexamethasone or prednisolone injection together. So works really great. I'll talk about some of the drawbacks based off of the study that I actually did at ICO with some of my students. So works really great. Typically, patients are really compliant. We see great results. It typically has the same amount of rebound inflammation after surgery as drops do in the literature. So they started using this drop in Europe, they started using this technique in Europe, and then showed that with the European population that it was still about 9% to 13% go on to develop rebound inflammation. So with our population, when we did our study, we were showing that about 20% of our population was going on to develop rebound inflammation 2 weeks post-cataract surgery. And that was way too high. We don't know if it's surgeon dependent, my study, or versus just the patient population. We know the African American population or people of color tend to have an increased chance for rebound inflammation due to pigment dispersion and causing more inflammation and irritation throughout the trabecular meshwork. So that irritates, the eye, causing more inflammation inside the eye. So that's one reason we stopped using Trimoxy, but we do use Kenalog now. So we'll do just a sub-conj injection of Kenalog just to help with inflammation, and that tends to not increase the pressure. Okay, so that was the other issue we were having with Trimoxy, is that pressures were skyrocketing. So again, every patient population is a little bit different, and you have to take that in consideration and what your surgeon feels comfortable doing and how good your surgeon is.
So technology surrounding cataracts is constantly evolving. Are there any new or featured developments within cataract surgery, IOL selection, or post-care that catch your attention?
So I think right now the multifocal toric IOL is something that it just kind of starting to come out. Some docs are starting to use it. I don't know what the success rate really is with that. Again, I don't do a lot of specialty IOLs, but I think that's the coolest technology out there right now, especially being someone that has ICLs myself. I was always worried, like, oh God, what if I had a high amount of astigmatism? How would I do that? Well, they're coming out with ICLs that are now, toric based as well. The other, technique that a lot of surgeons are using is LRIs, right? So they're using, laser to make small incisions to correct for astigmatism, which I think is really, really cool. And they're doing that oftentimes with a laser-assisted cataract surgery. So they'll actually cut the LRIs right there, in the cornea before they do cataract surgery. That's when they find that it's the best time to do it, not afterwards. So they'll do that when they do the laser-assisted to help with patients that want a multifocal lens but have mild amount of astigmatism that needs to be corrected. So I always think that that's a cool technology that's coming out. The new sterols for eye drops to help cure or cataracts, something that's really interesting to me. Again, if I can keep my patients away from surgery, that's what I want to do. So the sterols for eliminating cataracts via drop, pretty neat. I don't know if it's going to happen, but I think it's a cool technology to look at. And again, MIGS and cataract surgery together, they're making it so easy now that, most of our regular cataract surgeons are now also becoming glaucoma surgeons, which we need because we don't have any glaucoma surgeons left. Nobody wants to practice glaucoma because of the risk, and it's a really difficult condition to treat, and the surgical outcomes are so poor. So it's a hard department or career to go into. So, if we can get more of our normal cataract surgeons to be performing MIGS, especially eye stents, and eye stents have been a real great success for a lot of our, mild to moderate cataract, or mild to moderate glaucoma patients that have cataracts. So
what's the mechanism behind these like sterile eye drops? Because I briefly read that they're developing eye drops to eliminate cataract development or heal cataracts, but I don't know a lot about it.
I don't really either. I'm right. So it's the sterile is supposed to help with the crystallization, or decrystallizing the lens. So it's supposed to help kind of remove that crystallization that the cataract has caused. I really don't know, and they don't tell you a lot about it because I don't think that they're really sure how it works.
Yeah.
But there's some type of, I'm sure if you ask like a biochemist, they could probably break it down for you. But I am not one of those. So I think it's some type of, the sterile for some reason breaks down the opacification of the lens. The thing is, how much are we penetrating through the cornea to actually get there?
Yeah,
right?
to break that down.
What's the vector that's getting it back there, or the carrier? To not damage the cornea, first of all, to be strong enough to break this down. So I think there's still a lot of research, but I think it's a cool way to go.
And then I did quickly want to mention another cool development that I noticed in the news, and I was wondering if you knew anything about it. There's a new development that's still in the works. It's by Omega Ophthalmics, and the company is creating an artificial capsule that holds IOLs, augmented reality chips, and is available for medication delivery. So before this podcast, have you heard of this company? And if so, what are your thoughts?
I didn't hear about this company because of the patient population I work.
Yeah.
But after I got your questions that you're going to ask me, I was like, this is amazing. So with our patient population and how many issues we've had with trauma or poor capsules, right? So we get a dropped lens or really dense cataract, to have an artificial, a capsule, that would be awesome. We could eliminate anterior chamber IOLs, which we know don't always work great for our patients. We have more complications than good outcomes. And if they could, these microchips could help with low vision. I was thinking about that. That would be really cool. And then drug delivery for, glaucoma. How cool would that be?
Yeah. Cataract surgery is an area of optometry and ophthalmology that really hasn't been touched that much because, the IOLs work. So everyone's just kept it the same way. And then some people try to tweak the IOLs or the surgery just to make it better. But no one has really had an innovative, method of doing cataract surgery in a whole nother way. So I thought it was really cool.
It's really a 3D mechanism, which I thought was really cool. We just think of, this one area coming here, one coming here. And we don't think about the movement kind of coming back and forth, which would just be a cool axis to kind of move the whole lens around, and how many things you do with it.
It almost looks like an inflatable kiddie pool with the 3 rings. It was just really cute.
It is. It looks just like a little flotation device.
Yeah.
The implant. Yeah.
So Dr. Piser, as our last question, what advice would you give to new grad ODs to begin managing cataract post-op treatments?
So I think the number one advice that I would give to managing cataract post-ops, which is so fun. It's so cool to be able to do something different during the day instead of one or two. Let me fit you in. I mean, contact lenses are awesome. Like you can do a lot of fun stuff and like treating glaucoma, but cataract post-ops are fun. They're typically pretty easy to do, but if you're going to do cataract consults and cataract post-ops, is to find an awesome surgeon. And don't be afraid to interview a bunch of different surgeons and interview them, right? You're liable if you're going to work with a surgeon. So interview your surgeons, make sure they're friendly, make sure they're available. Like Dr. Dawson is the friendliest, biggest teddy bear in the whole world, and I can call him at any second. He'll come out of an exam with a patient to talk to me. He's there if I text him on a weekend, I have a question. I mean, the availability that he has for me makes me feel comfortable in treating his post-ops and doing his pre-ops. So having that availability, having a comfort level with your surgeon and knowing that he's a good surgeon, jump in. Try to see if you can get into surgery with them, what they're doing, how they're managing, what their techniques are, what technologies are they, using. The other thing is if you are going to work with a cataract surgeon, make sure you have a contract. Okay. So you're going to want to make sure how are you going to get paid for your visits, right? How are you going to get paid for your work? You either have to set up a contract regarding, are you going to be a part of the surgical process? So are you going to see them for their, non-charged visits, which means you need to get a cut of the surgery, or are you going to charge the patient when they come for their post-ops? Okay, so to get in and see surgery, if you haven't been able to see it, go in and see it. Just to learn what the patient goes through from start to finish is going to help you educate the patient on what they can expect during surgery. So especially if you're going to work with a specific surgeon.
Yeah. Definitely. I think glaucoma and cataract surgery is something that will never go away. So that's definitely important areas of optometry.
Yeah,
it's always going to be there.
Yep, and these surgeons are going to dwindle, and they're not. They are not going to want to do these visits. They're going to want to just do surgery because that's where they're going to make the money.
But yeah, Dr. Piser, thank you so much for coming on our podcast. I mean, we are so happy to have seen you after such a long time. You haven't changed one bit. So
thank you.
Thank you so much again. I think we learned a lot. Hopefully our listeners learned a lot. For any of our listeners who heard this podcast and is really interested in learning more about cataract surgery or co-management, are there any references or resources that you would recommend for ourselves and the listeners to either reach out to you or to learn more about, cataract surgical co-management?
Right. I think, the American Academy of Ophthalmology, their website is awesome. I always go there as much as possible to find any ways that we should be co-managing with ophthalmologists. I try to stay on top of, their newsletter and things like that with cataract surgery and upcoming, techniques and technologies and treatments and management. So that's one resource I use quite a bit. There's ASCAR, which is also another ophthalmology, where they do lenses, cataract surgery, and refractive surgery. That's a great, resource as well. So that's a great way to find information. But yeah, you can always reach out to me to dpiser@ico.edu. If you have any questions, just shoot me an email and hopefully I can help you guys with answering any further questions that you might have about cataract co-management.
Yeah, great. Thank you so much.
Thank you guys. I had such a pleasure, and thank you so much for having me on. I'm so proud of all of you. Thank you.
Thank you to everyone for listening to 4 Eyes. If you enjoyed this episode, please be sure to subscribe and leave us a rating to give us feedback on how we're doing. You can also check us out on Instagram at 4EyesOptom for more content. Look out for new episodes every Wednesday. So until then, stay tuned.